Medical Center in Brooklyn, New York, and also the infectious disease fellows at the Saint Vincent Catholic Medical Center, New York. The fellow of Infectious Disease Society of America for achieving professional excellence in infectious disease. He is recognized as the Master American Professional Wound Care Society. He was a past clinical assistant professor in the Department of Internal Medicine, Infectious Disease at the University of Toledo College of Medicine and Life Science, and past medical director of Hyperbaric Clinic and chief of the Division of Infectious Disease at Saint Rita Medical Center and Lima Memorial Hospital. He has multiple publications in a very reputed national and international journals and in the various fields like infectious disease, wound care, obesity medicine, with significant clinical research experience, having done 72 clinical trials. He is currently an associate professor for clinical Department of Internal Medicine at Mercer University School of Medicine, GA, and also adjunct faculty for the Center for Podiatry and Diabetic Food Care and Research at our institutions and university. And most importantly, he has passion for all things infection, wound and metabolic health related topics, with emphasis on the healthcare delivery, the transition of care and use of technology, including telemedicine, to break down barriers to healing. With this quick introduction, it's a great privilege for me to welcome Dr. Ravi Kamepalli. As I said, I know sir from the more than 7 years, especially with the Indian Podiatry Association. He is the Vice President of the Indian Podiatry Association at the national level. As at the Karnataka chapter, we work very closely with sir in terms of research and the academics and various scientific activity. With this quick introduction, a very cordial welcome to you to deliver the session, sir.
Thank you. Thank you, Dr. Maya. It has been a pleasure knowing you and working with you. I'll start sharing my screen here. So thank you for giving me the time and asking me to talk about this topic. Wound care has been one of the kind of neglected aspects of healing. And I'm an infectious disease doctor and who happens to have a passion for wound healing and also board certified in obesity medicine along with the other two specialties. I am located in Georgia in southern Atlanta area, and my website is nobadbugs.com. And my Twitter handle, X handle, is wound physician, and my passion is removing barriers to healing. I have one disclosure with me working on a comprehensive telemedicine-based solution for infectious disease, wound care, and metabolic health, and we're hoping to bring those tools, techniques, and process it at Manipal with the help of Dr. Maya. So let's begin with a case here. It's a real-life scenario of a 40-year-old female who's a security officer who's diabetic since age of 15. She does not know at that point that she was type 1 or type 2, but she has been taking heavy doses of insulin and ended up having a TIA and hyperlipidemia and GERD issues 1 month prior to developing the ulcer on the right foot. Detected to have peripheral vascular problem. I'll show you the pictures in a bit, but you see that she's taking diabetes medications with Troshiba and Novolog. This is Deglutac and Novolog with meals for a long time, and says that her sugars never were below 250 all her life. And cultures showed growth of Staph aureus and streptococcus. She was denied hyperbaric therapy because of insurance issues but then she ended up being brought to the office. We did unique dressings using a continuous diffusion of oxygen therapy with an oxygen diffusion pad, and debrided and used lactate dressing at multiple applications with local ultrasound mist therapy. And also, basically, she ended up having some renal issues that improved. So this is her picture. If you see, she's a necrotic wound, and this was moist necrosis though. Normally, when there is an arterial problem significantly, we don't try to cut on it. But this ended up, there was a moist area, so the podiatrist took the patient for debridement. And but then if you see, the tissue had become dusky here, and MRI showed osteomyelitis. And if you can see here, the blood sugars are noted to be high around 300s or so. Um, and she ended up developing, sadly, a Charcot foot here. And if you see the deformity here, and we started her on low carb diet, and she was on this insulin that we were able to take her off it. And also, if you can see, we had to put her on the Crow Walker boot. And these are the pictures during the process of healing, wherein we debrided every time and used local lactate dressing that helps, because if you are aware of it, when there is a wound healing problem, the pH of the wound ideally goes above normal, so it is alkaline. So this is, if you can see the pH strip, it's a simple, very cheap strip that if you put on the wound bed, you can say that the pH of the wound is higher here. So in these people, as this lactate dressing we use, that helped reduce the pH, and also ended up healing this area with local care. But what we did along with that was teaching her how to eat differently, and we ended up giving her a high-touch remote physiological monitoring platform, wherein we were able to track her sugars. And every time she comes, she's in the debridement chair. And as I'm doing the procedure, I ask her and talk to her about her nutrition. Her healing, her improvement was so good that we had an article that her case was in the article in the Guardian. If you look at it, I'll send the link to Dr. Maya, and basically, you guys, he can share it with you. But this was an important achievement of all the people that were in that article. She was the one, she still had her leg. Now we'll look at these topics here. What are we trying to achieve today is by discussing, understanding the scope of the problem, wherein concepts of metabolic health are integrated. We're going to discuss something beyond a calorie counting approach, and we'll try to understand where inflammation and immune responses are there in wound healing. And we'll try to integrate metabolic health discussion, collaborative approaches, practical applications, and also future research and some technology issues and key takeaways. As you know, wound care is a complex aspect of care delivery model where multiple caregivers are there, multiple specialties are involved, multiple comorbidities. Patient is never really in the center of the care, so everybody else is doing the care delivery. It's a multifactorial problem, and obviously this is delivered in multiple clinical settings, and that's a huge problem in care delivery model. So in diabetic foot, normally it's a global burden. You see that the global burden of disease by itself, there is depression, there is back pain, there is diabetes, but the diabetic related problems, lower extremity complications is 10th in that. And 1.2, every second, every 1.2 seconds, patients develop diabetic foot ulcer, and every 20 seconds, there's amputation going on. So that is the previous data from 2017. There are around 537 million diabetics now. And basic problem is they are living longer, increasing life increases longer complications, but also 19 to 34% of them develop diabetic foot ulcers, and these lead on to 20% of the people with diabetic foot ulcers and with lower extremity amputation that is increasing over the next 5 to 10 years. And We just have to come up with some techniques of improving and preventing this. And what is happening in diabetic foot care is there is foot at risk, and there is ulceration, there is recurrent trauma, and there is a problem also is there is that those are all leading to limb amputations and mortality. But the issue really is poor access to care and metabolic health that is not optimized. Say in African Americans, they talk about social determinants of health. But the problem is metabolically, when they are not fed the right food, culturally they have been troubled because the food that they were given through the culture had not been the same one they ate in Africa when they were brought over to America. So that affects them. And also food habits over the years changed in the last 50 to 60 years. We have people at risk with retinopathy, kidney disease, cardiovascular disease, and foot at risk with problems with prior ulceration, edema, and also mid-foot collapse, and other problems with the deformities where there is contracture of the toes. And as you can see, the cost is very heavy in diabetic foot ulcers. In US, it costs around $28 billion with 150K amputations. And for Medicare, it costs around $8.2 million, which is almost 15% of Medicare cost. And the 37 million Americans have diabetes, 96 million have pre-diabetes, and 1.4 million new cases are diagnosed. Basically, the rate of growth of diabetes is unprecedented, and this increases the burden on the care delivery models. There is increased cost, and these amputations have to be prevented, and there are multifactorial approaches to that. The reason for this is huge, that we have to be careful understanding that, because the direct cost, if you see for diabetes, is around $237 billion. And of this, mostly it is ending up with the diabetic foot amputations and diabetic foot care too. Whereas when you compare to cancer, it only is $80 billion. And the 5-year mortality rate is a lot higher for diabetic foot ulcers, with 46.2% having a mortality within 5 years in minor amputation, 50% with major amputation. Whereas with breast cancers, it's only 9%. Only lung cancer is the one that has a higher mortality than diabetes-related lower extremity amputation complications. So the primary prevention is where we have to go. And if you see the system cost of diabetic limb is higher, the problem is everybody, like orthopedic surgery, is doing their thing, vascular doing their podiatry, doing radiology, and the whole care is kind of broken. The patient is not in the middle, and different services, including all the say endocrinology services, plastic surgery, infectious disease, podiatry, orthopedic, and all these services are not built around the patient. That's a huge problem. So this was a study done wherein 30-day readmission rate in a single center was seen, wherein it was shown that the 30-day readmission rate increases, and the cost without readmission is $28,000 in this center. With readmission, the cost was $79,000. And basically, cost of diabetic foot ulcer over 4 years was $7.9 million, and readmission rate was $1.2 million. So we have to focus on preventing readmission, and essentially different techniques have to be used. Now, here, as you can see, this is another study done where it showed that in this is a single center study too, wherein it showed that to do amputation, it costs around $50,000 for orthopedic surgeons, whereas in $90,000 for dialysis. In self-management of diabetes is only $1,000. So obviously, self-management of diabetes has to be taught to the patients. Why should we do that? I mean, if you understand this, it is about as understanding that there's no such thing as a little diabetes or touch of diabetes. Whether they have diabetes or don't have diabetes, that's the key. Why should we say that? Is because when there is hyperglycemia, there is glucose that is very rigid planar molecule. What happens is it damages the epithelial cells and nerves, and it goes and coats those the areas causing platelet aggregation, inflammation, endothelial dysfunction, leading to different complications and peripheral artery disease and atherosclerosis. Why does this happen is because of formation of something called as advanced glycation end products, AGEs. And for fructose, so remember, the table sugar that we have is a combination of glucose and fructose, 50-50%. And when you have fruits and fruit juices that people eat and drink, you have to understand that fructose is there in it, and it causes 7 times higher advanced glycation end products. So here, in the hyperglycemia causes these AGEs, advanced glycation end products, and this accumulation leads to development of complications, including retinopathy, nephropathy, and neuropathy. And the wound healing is a major problem because when the elevated glucose is present, it causes neutrophil inefficiency and depletion. Since neutrophil depletion accelerates wound resolution independently, we just have to make sure that um, the neutrophil activity is optimized. So why should we do that is because when there is elevated glucose, say if this was a study that was published in 1973 that showed that when the carbohydrates were given, the blood, they drew the blood cells and they found that the neutrophil activity is phagocytis activity normally is good, but when there is glucose, it is problematic for 2 hours postprandially, and that affects last till 5 hours. The phagocytic activity is reduced. How does this happen is glycation again, wherein the problem is glycation interferes with even immune function, affecting the nature killer cells through formation of something called as methyl glyoxal, MGO, and that glycates the natural killer cells, and that problems prevents the tumors also from being taken care of by these natural killer cells. So the end game of medicine is what we are dealing with. We are playing something called as a whack-a-mole of medicine, wherein we are beating if you ever heard about the game of whack-a-mole, you're beating the problems around, but we're not solving the problem. And in this end game of medicine, basically, patient is having problems with diabetes, cirrhosis, pancreatitis, neuropathy, nephropathy, and all these effects are rampant. And this metabolic syndrome is a huge idea. So metabolic syndrome, as most of you might know, is a compilation of 5 criteria: elevated blood pressure, elevated blood sugar, high triglycerides, reduced HDL, and waist circumference. The 3 out of 5 is called metabolic syndrome. And basically in this 2 studies, if you see by 2016, they showed that in US that the people who have metabolic syndrome was 88%. Only 12% of people were metabolically healthy, whereas by 2019, this article was published in, I guess, in 2022. The metabolic health continued to worsen. So obviously, cardiometabolic health has underpinning issue with metabolic syndrome that has at its root insulin resistance. Now, let's focus on wound care and try to discuss wound care because that's what the topic we're trying to come to. But without understanding the basics, I think we will not be effectively understanding the topic completely. So there's local factors that contribute and systemic factors. The tissue architecture, the resident cell types, and regenerative capacity had to be understood. And also characteristics of tissue damage, whether it is mechanical, chemical, or wound microenvironment. How is the tissue oxygen? Systemic factors include the genetic factors, age, obesity, medications, and the kind of diet. And the common trends in wound healing that is poor is a dysregulation of extracellular matrix, bioburden imbalance with increased infection, cellular senescence, impaired angiogenesis, and wound hypoxia, and malnutrition and pressure. If you understand one thing, there is impaired angiogenesis in wound care, but in cancer, there is increased angiogenesis. So I'll pause that for now. We'll talk about that later if you guys have any question. But this whole process is needed to remove barriers to wound healing. So the current challenges in wound care are not doing primary prevention, secondary prevention with recurrence prevention of new ulcers has to be done. We have to understand that we have to understand what is the patient's agenda. Patients don't want amputation. They will do anything to make sure that they don't have amputation, but how are we helping them get there? How are we getting the prevention of amputation going on? So we have to understand the infection, trauma, vascular disease, neuropathies, and also understand that when there is dysglycemia, there is problems with the patient's white cells, and there's abnormal changes in the when there is high glucose present, the bacteria are not able to be taken care of. And uh, coming to the process of wound healing, we have to understand that in the basics of wound healing is repeated trauma, presence of ischemia, tissue injury, and bacteria. This increases inflammation, increasing neutrophils, increasing macrophages and mast cells, and increasing the TNF alpha interleukins, and causing increased MMPs and reduced tissue inhibitors of matrix metalloproteinases, and increasing reactive oxygen species. And that leads to continued chronic non-healing ulcer. Now, you have to understand the biofilm-based understanding of wound care is huge. So basically, that's a whole another topic. That's a 1 hour lecture on biofilm. But to quickly put it together, there is something called as accumulation of this bacteria. When there is quorum sensing, there is increased release of toxins, and that causes the problem. But as the bacteria is present on the wound bed, you have to see that there is slow penetration, there is increased stress response, altered microenvironment. But like cancer, there is persistence of this bacteria deep into the tissue. So those are called persisters. So how do you do is you actively debride. You do the offloading, you do the active assessment of infection. Nowadays, they are doing the PCR technology to identify the DNA of the bacteria and appropriately offload, de-escalate, and then go back again to maybe if the wound is not healing right, use adjuvant therapies like skin substitutes, and then go on to use grafts or negative wound therapy, and in addition to the rest of standard of wound care. The multiple pillars of chronic wound healing problems include obviously aging, reactive oxygen species, deficient metabolism that is intrinsic to the metabolic process of that patient, and chronic inflammation, infection, and nutrition. We'll try to focus on nutrition in wound care at this point. We'll hold off on rest of the discussion, but we have to understand that wound healing is a dynamic, continuous process, and these process of clotting, inflammation, migration, and remodeling, all these phases are overlapping. But for our convenience, we have put them into those classes. So in this definition of malnutrition, okay, it's like metabolic syndrome itself. So whether when there's issues with malnutrition identified, how are you going to identify them? It should have 2 out of the 6 criteria. There has to be insufficient energy intake, weight loss, loss of muscle, loss of subcutaneous fat, but also localized fluid accumulation. So there is extracellular fluid that accumulates, and that might mask the weight loss though. So weight might be fine, but there might be generalized fluid accumulation. Obviously, as a physiotherapy department, you guys know that assessing hand grip is one of the functional status that needs to be factored in. So you take these factors and decide whether there is starvation, there is malnutrition, and then whether it is mild or whether it is marked problems, including the patients who have had a burn or trauma or closed injury. So in between this whole critical component of the wound healing process is involved the imbalance of anabolism and catabolism. So in conditions where there is increased stress, there is increased catabolism, and there is this can complicate healing, and this leads to development of protein calorie malnutrition. So in patients who are admitted in the hospital in diabetic foot ulcers, you have these patients with prolonged hospitalization where the patients are losing their muscle mass, their factors like albumin is going down, and the criteria for further assessment was established by this global leadership initiative. Criteria is crucial to understand it, and also uh, approximately assess it a few times during the hospital stay and try to implement changes. You have to understand that there is significantly reduced muscle mass. So what I do in my office, even for diabetics and non-diabetics, is try to assess their muscle mass to do by doing bioimpedance testing. I hope you guys have it, but I think bioimpedance testing is going to be the next level. Malnutrition and muscle mass has to be addressed too. So not many of societies have developed real core malnutrition, addressing the right kind of nutrition. There is a talk of different micronutrients, but this society, American Limb Preservation Society, has come up with this thing where they talk about screening the patient, all of them, and assessing them and ensuring problem quality measurement of different things, malnutrition assessment, and create individual plan, see if they're well hydrated, try to understand weight loss, nutrition, hemoglobin A1C, and provide regular education. And these are quality metrics. It's more for a system level thinking wherein they're talking about, okay, whether you did the job or not. But the question is, what is happening at the individual level? At the individual level, what we are taught is, okay, micronutrient deficiency is huge. Yes, I agree. But insulin resistance is also a part of this whole assessment that has to be completely done. And we in this whole process simply neglect nutrition, and particularly calorie restriction has a severe impact. Now, I'm talking against calories, but also here I'm using the word calorie. So you have to understand that calorie is a measure wherein you burn any gram of tissue, say, and you produce X amount of calories. But the problem here is that we don't have a calorie receptors in our body. So let's understand that. Let's make a difference of that, because it is what the body does to the food that we eat that makes the difference. The hormonal response of the food is what we have to address and understand. In this, you can see that vitamin A, D, E, C, K, zinc, and copper, omega-3 fatty acids are given. To understand nutrition well, we have to understand what insulin role is. So you have to understand that the macronutrients are three: protein, fat, which protein, of course, we need for collagen synthesis and inflammation, cell formation, and also we have to understand that the fat carries A, D, E, and K, but there is no 1 gram need of carbohydrate. So the reason why I say that is if your system is well optimized, we don't need carbohydrates, because the carbohydrates that we eat from outside, when we have 5 grams of glucose in the total of 5 grams of glucose in our blood. So anytime our blood sugar goes more than 100 milligrams per deciliter, say 120, 110, or 126, beyond 126 at least, when it is persistently high, say 40 milligrams beyond that, that high excess sugar is converting into something else. I'll show you that in a bit. But let's go through the pathway of diabetic foot complications, wherein the sensory motor neuropathy is happening, autonomic neuropathy is happening, leading to the dry skin, putting the foot at risk, and leading to different neuropathy complications and further worsening, including chemical trauma and neuropathic changes that are leading to the problem. And neuropathy, vasculopathy, and persistent hyperglycemia leading to trauma, infection, and diabetic foot ulcer causes the morbidity and mortality in diabetic foot ulcer. In diabetes and infection, this is a complex interaction where diabetes with hyperglycemia affects the innate system, adaptive system, and host responses, leading to infection, and that in turn affects the insulin resistance and beta cell function, causing the immune system having issues with response, and also leading to complications. And you have to understand that with infection in the presence of diabetes, there is around in diabetes there is around 1.5 to 4 times fourfold risk of infection. So how does this happen is because of increased stress hormone, production of cytokines, beta cells, and insulin resistance, and diminished insulin secretion and hyperglycemia. So in the host factors, there is alteration of gut flora and alteration of the skin flora. There is integrated changes where peripheral vascular disease changes causing autonomic neuropathy, increased intestinal permeability. The mucosal layer is gone, and the mucosal integrity is gone too. And when there is that problem, then there is issues with innate immunity where the complement system is affected, neutrophils are affected, natural killer cells are affected, and the antigen presenting cells are impaired, and there is TH cells abnormality and reduced cytokine release. So we talk about neuropathy, vasculopathy, and infection, but also we have to understand that there is significant need for us to understand the immune cells, the macrophages, the neutrophils, and also endothelial cells and keratinocytes. So there are four aspects to diabetic pathogenesis that can happen with physiological, pathological mechanism, but also understand that these effects can happen at molecular signaling level, wherein these signals are disrupted and epigenetic changes happen, leading to complications. So there is significant issues with increased inflammation, leading to problems with persistent diabetic foot ulcer and clotting happening and remodeling that is very slow. So here we talk about alteration of the metabolic pathway of wound healing in different stages. There is increased oxidation, there is increased TCA cycle, different changes in the mechanisms wherein the metabolic process of the basic wound healing is compromised. And the concept that very much I want you to not forget is the macrophage thinking. In the metabolic health and wound healing, there is in persistent inflammatory state, the macrophages are M1 macrophages. So in the early inflammation stage, when there is injury happening, the white cell, the platelets release, and the monocytes come in, macrophages are seen, and we need M1 macrophages in the initial part. But what is happening is in the later part, later we have to get M2 macrophages. And in the immune aging process too, in the diabetic foot ulcers, there is increased activated end products of glycation, and there is oxidative stress and DNA damage, and that leads to sustained immune inactivities that is leading to inflammation, and obviously problems with cytokines and presence of disease-associated molecular patterns and pathogen-associated molecular patterns are involved because of all the complications of hyperglycemia, increased interleukins, and pro-inflammatory state happens, and continued problems with changes with innate immunity is happening. So again, the immunology of wound healing is complex, where initially, when the hemostasis happens, platelet plug happens, the phagocytosis starts. And what is happening is when there is inflammation, there's a group of the neutrophils form. And neutrophils forms, and the neutrophils form together called netosis. The neutrophil come together, form a net, and they kind of take the bacteria and kill it. But when there is complication in the wound healing, is that netosis is affected, and basically the problem with mRNA and Treg formation and proliferation is happening. Obviously, all these pathways are affected, including PDGF and interleukins and TNF alpha. So, like I was talking earlier, this effect is seen also in the cells in the bone marrow level. So in the bone marrow level, this happens, and also the M1 macrophages are persisting, and there is increased reactive oxygen species. But as the healing goes through, M2 macrophages are formed that leads to RNA interference, DNA methylation, and histone modification, and epigenetic changes are happening, preventing appropriate wound healing. We'll skip this one; it's a little too deep. So, but I just wanted to show you that this is a drainage from the wound showing some bacteria. And this shows that when the presence of these bacteria, the macrophages M1 phenotype is persisting, and macrophages respond to secreted factors from these microbes, releasing, upregulating the inflammatory parameters. But if you can see the macrophage, when done right, the white cells eliminate pathogens in amazing fashion if we are appropriately taking care of the wound bed. So we'll go to the next one. So again, we come to the concept of that M1 and M2 macrophages. I want you to understand one thing. The macrophages, though, that is for our understanding, we have classified them into M1 and M2 phenotypes, but there is multiple spectrum. If somebody wants to take a deep dive on macrophages in wound healing, that's another aspect that is very interesting and complicated. The same regarding MMPs too. So that's another huge aspect. So here they use this ON101 cream, and they showed that when they had when they use this cream, the M1 is reduced and M2 macrophages are there. And when there is M2 macrophages, the healing happens. So we have to understand that when there is insulin resistance, okay, when there is insulin resistance, so most diabetics are, I should say, all diabetics who are type 2 diabetics are insulin resistant. So their macrophages are moving from M1 to M2 phenotype. So do you see how significant this is that leads to macrophage and meta-inflammation and immunometabolic problems? So again, you have to understand that the clotting is happening, the cytokines are being released, the M1 macrophages, the neutrophils are coming together, and netosis is happening, and the bacteria are killed, the M2 macrophages come in, the wound heals. That is all disrupted in diabetic foot ulcers. And in a diabetic foot wound, if you can see here, M1 macrophages are there, but in the healing wound, the M2 macrophages are better. So in high glucose environment, this is a mouse model. They gave it when high glucose was given, there is increased reactive oxygen species, increase in the mitochondria, in the T cells, and there is also increased Th17 activity, and that causes gastroenteritis and autoimmune problems. So TGF beta cytokine activity is there. So this is one study that made me interested about low carb nutrition in wound healing in 2016. So this was a thesis by one of the PhD doctor in University of South Florida. They did mouse study, aged rats, I guess. They gave exogenous ketones, and that showed that ketones increased proliferation, advancing migration, reducing reactive oxygen species, and resolving inflammation. So that made me start thinking about ketogenic diet in wound care. And then I came across this one, wherein they showed that beta hydroxybutyric acid in an ulcer that has Mycobacterium ulcerans, and that is very significant. It's a TB-like organism, and when you have beta hydroxybutyric in that model of mouse, then they are having that controls the infection, and the ulcers went on to heal. So if you see here, in wounds, in all diabetic wounds, there is increased inflammation, reduced macrophage activity, it's keratinocyte migration is reduced, endothelial cell migration is reduced, and all these are affected in diabetic foot healing. And this happens with DNA damage, endoplasmic reticulum stress, mitochondrial injury, and irreversible damage happening. So this is one schematic that is I like this schematic very much. If this has hyperglycemia, when there is hyperglycemia, there is increased glycolysis, there is increased AGEs activated and products of glycation. And there's increased reactive oxygen species production, but also increased sorbitol production. I'll tell you the importance of this one in a bit. And sorbitol gets converted to fructose, and again the reactive oxygen species react to nitrogen species are forming. And here, when there is increased glycolysis, the signaling pathways are changed. There is inflammatory pathway, and there is this NF1 kappa beta. This is very important. You remember this one. I'll tell you this is very important. And there is increased inflammation leading to cell death, and also oxidative phosphorylation is happening, and there is reactive oxygen species DNA damage, PPAR pathway activity, and the ACE pathway, polyol pathway, PKC pathway, and hexosamine pathway, and oxidative stress leading to all these problems. So obviously, the same thing, the multiple areas of hyperglycemia causing all the problems of sorbitol, activated end products, multiple studies that I try to bring together to show you that inflammation has a significant aspect to it. We need to understand that there is options for it, including using different drugs, SGLT2 inhibitors or new kid on the block, and there is GLP-1 agonist too. But SGLT1 is they improve inflammation and endothelial function, but also they work through NRF1 pathway, and obviously they promote angiogenesis, different things, including statins to help. But there is reduced inflammation, but that statin effect is not because of LDL reduction. That is a pleiotropic effect of statins, not the direct LDL reduction, the inflammation reduction, the C-reactive protein reduction. That is what is happening. So other drugs like cholesterol for anticoagulation and therapy for infection, we know that. And basically gels and all those are there. And N-acetylcysteine also is being used as a possible wound healing accelerant. So I was talking about sorbitol earlier. When there is excess glucose, say there is excess glucose floating in the blood, and you say, oh, 200 blood sugar, that's fine. No, that's not fine, because that excess glucose is converting to sorbitol. And the sorbitol is kind of stuck. This is a polyol sorbitol pathway, wherein through which the glucose is converting to fructose. So fructose, by the way, is not detected in the blood. Your blood finger stick is not going to detect fructose. And on the top of this, when this fructose is elevated, or the sorbitol is elevated, there is formation of this causation of diabetic retinopathy, neuropathy, and all these are processes that is continually causing trouble. So in the dietary areas, the omega-3 fatty acids are noted to show improvement with alteration of expression of MMPs, and also macrophage activity is improved. The epigenetic factors are better, and also skin microbiota composition is improved. And fish skin substitute grafts are also being used. In metabolic syndrome, there is increased TNF alpha, there is MMP increases happening, and there is the higher surgical complication in metabolic syndrome. So lifestyle changes are very important. And obviously infection, inflammation, and wound outcomes are depending upon metabolic health. So coming back to beta hydroxybutyric, what is it? It's one of the ketone molecules, beta hydroxybutyric, acetoacetate, and there's a third one, I'm skipping on the name, propionic acid. So beta hydroxybutyric acid, propionic acid, and acetoacetate. All the three are through which the ketogenic pathway is happening. But I was talking to you about NLRP3 pathway and also NF kappa GA, that pathway I was mentioning earlier. That affects against this NLRP3 inflammasome. So beta hydroxybutyric acid directly blocks the inflammation. It reduces the oxidative stress. So this is very effective in clinical outcome. And we have to understand that in metabolic health, inflammation, in the inflammatory state, energy is very much needed. Everywhere in proliferation state and in tissue remodeling state, energy is needed. Ketones and inflammatory responses happen. Ketones have anti-inflammatory response. They reduce oxidative, they reduce excessive inflammation, and also they are energy source for immune cells. better than energy source from the glucose. Then they improve the blood flow and reduce oxidative stress. So there is a immune function improvement, blood flow, oxidative stress, and anti-inflammatory action. And in glycolysis, with glucose metabolism provide ATP through these enzymes, hexokinase, pyruvate kinase activity, and lactate dehydrogenase activity. In lipid metabolism, there is enhanced beta oxidation providing ATP. And increased lipid synthesis supports cell proliferation and extracellular matrix formation, whereas with amino acids, there is collagen synthesis. And obviously, therapeutic benefits of ketones is enhanced energy production, reduce inflammation, support of cellular function, and modulation of inflammatory mediators. So we discussed this, but I want to talk about reperfusion injury when there is arterial ischemia, when the angioplasty is done or vascular bypass is done, then the reperfusion damage is happening. So, but ketones prevent these things through prevention of the ischemia reperfusion injury through anti-inflammatory response, attenuation of oxidative stress, epigenetic regulation, and also effects on energy supply restoration and effects on mitochondria. So this was an opinion piece in 2020 that we wrote, wherein if you see the concept in social preventive medicine, we are told that there is genes, there is environment, there is lifestyle. But what I went on in my clinical practice, as I was doing my infectious disease, got into wound care, then into obesity, and I came up with this idea that, hey, this process affects lipid system and immune system, that is immunometabolism. Okay, that is lipid driven and also affecting the microbes and microbiome. So with that, I want to tell you also in this study, this was just an opinion piece in 2020 published in University of Louisville Respiratory Medicine Journal, wherein we said that if you are able to augment the T cells by improving the T cell function through low-carb nutrition, then we can fight COVID. That was an opinion piece. I based it on that the T cell study done by Dr. Dom D'Agostino, and also there was a study in 2019 that showed that when the mice were exposed to influenza in the presence of ketones, their infection risk was nil. So arguments, I was talking about calories and beyond calorie approach, wherein you have to understand that hormones are more important. Insulin is more important, and also glucagon responses. So the ketogenic diet benefits by reduced inflammation, improved cellular repair, and metabolic fitness is there. And basically, individual variability happens, and and also there is what is the cons is there is nutritional deficiencies that have to be addressed, and in those nutritional deficiencies are easily addressable. And we have to understand that we have to integrate a personalized nutritional plan and education and support, combating processed nutrients and dense foods, and we have to bring in a multidisciplinary approach and professional-driven, patient-centric, holistic, platform-based approach. That's why I came up with this concept of bringing ketone measurements, clinical guidance, all these processes into one state wherein we have a state of nutritional ketosis through which we can come to by using limiting carbohydrates, adequate protein, adjusting for flavor, create a patient-centric, provider-driven solution that is significant for care delivery model. And I was able to do that. And this was a poster presentation. And if you want to, I have details on this poster presentation down here, but suffice it to say, you can scan the barcode here and you will get the details of all the presentation here. But what I want to tell you is diabetic foot ulcer heals by 12 weeks. And in the diabetic patients that were compliant with the dietary lifestyle that I've given, we were able to heal it by 9 weeks. So this shows that nutrient augmentation with appropriate insulin sensitizing approaches do help with healing. So this is the platform that we use, wherein we are able to bring in the patients, teach them their blood glucose and wound care, wound pictures, and bring them together and compassionately deliver a program that is easily done with a team-based approach. So the goal was to prevent the patients from falling into the river, and instead of catching them down the stream, we were trying to see if we can prevent that. So by using this comprehensive approach, we can do a predict and prevent, recruit the right team, identify the well-defined use cases, and use big data and integrating analysis and drive adoption by the patient. Simple process is bringing all these tools, techniques, and processes and improving the diabetic foot care. We have to understand that it's not just about bacteria, biofilms. It's not about just tissue mechanics, but a lot of it's not about comorbidities. But there's a lot that has to be done with access to care, and we have to approach this with a whole person approach. Point of care solutions like dressings and simple techniques that we use help, but we need a comprehensive approach that empowers the patients. Wound care is like a wait and see specialty. In fact, all medical care is the magic of medical care happens in follow up. The key is tracking an intervention like, say, blood glucose or the wound healing, tracking a picture or tracking the trend of healing, what they are eating, and how we can guide them. Coming away from mass medicine mindset to a power of one medicine is what I'm hoping to achieve. And one final slide. If you guys want, I have 3 other cases, but I think it's a long presentation. So I want to stop after this one. You have to understand this. You see this reverse blood vessels, trees, branches, roots, and you see these fruits and the notes, the musical notes. All these have a rhythm, and we are not recognizing the rhythm of healthcare. So that's what we are missing in real care delivery. And hopefully down the road, working with Dr. Maya, I'll be able to bring this whatever I do to Manipal, and hopefully we'll be able to deliver. That um, to the people that you're blessed to serve. Thank you very much.
Dr. Tina, can you ask the delegates if there are any specific questions to be asked to Ravi sir?
Yes, sir. We'll start the question answer session. If the audience has any questions, you can ask now. Any students from nutrition or medical lab technology? Yeah.
Good afternoon, sir.
Yep. Hello.
Wonderful talk, sir. Thank you so much. Sir, I had one question. Sir, do you think that maybe in case of ulcers which are probably smaller in size and probably are healing well, any kind of non-weight bearing aerobic exercise would help? Maybe light intensity.
So remember, walking on a foot that is injured is like one step is preventing healing by one day. Okay.
Okay.
So
Okay.
basically, what we are trying to prevent is uh, uh, trying to prevent the healing or improving the healing. What are we trying to do? So when you're talking about exercise, we're talking about pressure application. So if you're trying to offload, then if the wound is on the heel, so what we can do? Are you doing a TCC cast, or where is the ulcer? Or are you with appropriate ulceration? Is appropriate ulcer offloading is what we have to do.
Okay, sir.
So
So,
where is your ulcer? That's the question. So remember, a mass recommendation is kind of useless, and
oh,
you have to tell me where your ulcer is. So, and then you have to tell me how deep the wound is, and you have to tell me, did you optimize the blood circulation? Did you make sure that the infection is taken care of? Did you then offload? What are the tools, techniques, and processes you took to offload the wound? Then, rather than me telling go and exercise. Now, let me tell you, understanding nutrition and understanding infection and understanding diabetic wound care, I can tell you 80% of the problem has to do with nutrition.
Yes.
20% is exercise. Now, if you can teach them how to eat better, okay, that might achieve your goal.
Yes, sir. All right, sir. Thank you so much, sir.
So we have one more question from a student from clinical nutrition department.
Good evening, sir.
Yes.
So as you mentioned that calorie restriction like will impact infectious diseases and also I mean the especially and restriction of carbs, and you also mentioned that carbs does not really have an actual function in our body, but then in diabetic patients like they will be given insulin, right? So we need certain amount of carbs or but otherwise they'll go in hypo. Even in ketogenic diet we have like calories, so there has to be certain calories, otherwise the patients will go in hypo. So what do you have to say about that, since you told that carbohydrate does not generally have like a role?
So, and thank you very much for asking that question. So, number one,
Yeah.
we have to talk about fat adaptation. Okay. So, what is fat adaptation? Okay. So, is wherein, say, if you are eating food, any food, the sugar goes up first. Okay. Then the insulin goes up. Okay. And to bring then the sugar comes down, and sugar goes down and converts into either fat or used for energy, whatever. So now when the sugar goes down, the patient becomes hypoglycemic. Okay. And then ravenously hungry, goes on to eat. So when we are talking about in an insulin sensitized person, okay, so trying to give them adequate protein and fat is very important rather than giving them carbs. Why did I say that? So did you understand what I said?
Yeah.
Giving them protein and fat is more important than giving carbs, because in those calories, what happens is that when you're giving carbohydrates, you're stimulating this insulin, the second spike, higher than when you give protein. When you give protein, the insulin spike is only 40%. When you give fat, the right kind of fat, the insulin spike is only 4%. So you are able to give them the calories, and also you're not giving them insulin spike. So what do I mean? That we have to understand, when with diabetics, there's a complex thing that we are not taught right. We are taught about glucotoxicity, but we are not taught about insulin toxicity. So do you cook at home?
Yeah, sometimes.
So you go walk into your kitchen tonight, and
Yes.
your kitchen tap is on, the sink is clogged, there is water on the ground. What is the first thing that you will do?
I will off
Let
the
me repeat the question again. Let me repeat the question again. I want the right answer. You walk into your kitchen tonight, your sink is clogged, there is water on the ground, the tap is on. What is one first thing that you will do?
I'll off the tap.
So that's a great thing. You chose right. Now, human body is like a pot. This pot is full, and it is toxic energy is floating around, and the tap of food that you're putting in is there. So what is floating around in the blood is glucose. Okay.
Yeah.
And you have to understand that we have to stop the tap of glucose. Now, we have, with tools, techniques, and processes that are available right now, we can safely de-prescribe, like I did for that lady. You got me? So you might not have a continuous glucose monitor, You can do SMBG, self-monitor blood sugar, and by the way, down the road, as a part of this platform, we are also going to bring teaching tools, Dr. Maya, wherein we will be certifying, we will be getting all the ideas that I'm a part of an organization in US that is trying to spread the knowledge of low carb therapeutic carbohydrate restriction, which we will bring using a network of nutrition network through Society for Metabolic Health Practitioners, which is a big group of doctors that are focused on evidence-based guidelines for therapeutic nutrition and also de-prescription. So her question is very rightful and also needs addressed the right way. There is a de-prescription protocol. So we need to have pharmacists on board, and I will be able to then guide the pharmacist. We can go through the nutritional approach to pharmaceutically de-prescribing. So we can get, I will be then, as a part of this whole teaching process, I will bring on different areas of collaboration wherein we can take the pharmacist and we can work on de-prescription of diabetic medications. So this is going to be an amazing approach to overall clinical improvement. Thank you for the question, though.
Thank you, sir. Thank you.
Any other questions from students? So one last question.
Why only one? Ask more.
Sir,
Okay.
thank you for the talk. I have one question. So you were talking about the fasting improves the immunity and the neutrophil function, sir. So if a diabetic patient is there on oral hypoglycemic agent, so
Stop
how
it.
much of the fasting period, maximum fasting period is recommended for that patient, sir?
So
Or 2
basically,
hourly diet we should give, sir?
no, basically, you as if you're delivering a decision making regarding the medication, okay? So if you're telling somebody to fast, so people fast at Ramadan, people fast at every religious events, okay? Now the question is that, have you ever been on a roller coaster, by the way?
Yes, sir.
Okay. Can you be on the roller coaster for like the rest of your life?
No, sir.
Why not?
It will be nauseatic, sir.
Okay. So this is what is happening with the roller coaster of glucose.
Okay.
You don't want that. You want nice, stable flow, like a smooth river of life. Okay. So you don't want that. So what is happening in this glycemic variability, we are trying to avoid. So when you're taking medications from outside, is you that the in the earlier example of the kitchen sink, where we are then mopping. Now we are giving these drugs to mop the floor. So now you're giving one drug, you're giving 10 drugs. So then you have to understand that the oral hypoglycemics are the first ones that are going away in this protocol. Because number one, the oral hypoglycemics are not predictable. Okay, and you cannot reverse them. And there is protocols that we have, or foods for hypoglycemia to eat when these kind of problems are there. So that, say, you don't want to tell them go and have a chocolate or a bowl of sugar, because then you're exacerbating the problem again. The glucose goes up, the insulin goes up. So there are low insulin toxic foods or insulin resistant, insulin spiking foods that are available. So that is what we have to advise. So oral hypoglycemics, if this is a path of a process that they are going to follow, first thing first, oral hypoglycemics go away. You don't have to worry about a little bit of hyperglycemia for a few days. You got me? So it will improve. And finally, also, I want to tell you guys one thing. So have you ever seen the taraju, the lady gesture scale, the scale like that? You know, the one that they measure, the scale.
Yes, sir.
Okay, so if the scale is in the middle, the middle lever is the insulin, and this side it is glucose. Okay, when you eat carbs, the glucose goes up, the insulin goes up. This then converts the glucose into fat. Here, when you're fasting or eating protein, the insulin is down. Okay, the insulin goes down and the fat comes out, because at any given time, the fat is not going to be released out of the body if the insulin is high.
Okay,
You
sir.
got me? So
Yes.
if somebody is burning fat, or if somebody is losing fat the right way and reducing their fat mass, you have to understand that their insulin is better, their insulin sensitivity is better, so they are burning fat. And the way the fat is burnt, or the way the fat is released, I should say, is through the breath. Okay, as acetone. Okay, and you are acetoacetate when you pee out, or it is in the blood as a beta hydroxybutyrate. So this concept is very much necessary for you to understand that the glucotoxicity is being monitored, and we are using insulin to reduce this, but nobody's thinking that by giving more insulin, they're causing more insulin toxicity.
Okay, sir.
So diabetes is a symptom. Diabetes is not a disease, okay?
Okay, sir.
The real disease is hyperinsulinemia and insulin resistance. And that is the problem. The issue here is that we are treating the symptom of diabetes with high insulin.
Okay, okay, sir. Thank you so much, sir.
Mhm.
Any more questions? So that was the last question. Now I request Dr. Arunmaya sir to give the closing remarks for the session.
Thank you, Ravi sir, for a very excellent session.
Thank you, sir.
I think in the near future, definitely we would like to invite you to visit our institution, having more interactions with our students of all the disciplines. Definitely your rich experience, the skill or the knowledge in the field will be definitely going to be very useful to all of us. Thank you. Thank you very much for it. Thank you, sir. Thank you, sir.
Thank you very much, sir.
Bye, sir. I will call you in the evening, sir. Maybe with Krishna, we will have that discussion.
Okay. What time you can text me the time, I will tell him.
That time I'll just message you that. Huh?
Thank you, sir. Thank you very much.
Bye, sir. Bye.